somewhere in the bottom left hand side where actually you may be line managing an advanced clinical practitioner, and one of their pillars of practice, as we know, is research. So it might be actually talking to them about how they really develop that portfolio of research that they're either supporting or leading on. Do they want to become a principal investigator? How do they go down that route as well? So the idea of the tool, it looks at everybody along that research pathway to be able to support them at every point. So this was the tool that we devised about the what, how, why, and when the chosen objectives can be achieved. Next slide, please, Declan. So what we did then was we devised the tool and we thought, oh, we best pilot this, see how it goes. So we were fortunate that one of my matrons at MFT was successful at being part of the NIHR 70 at 70 programme, which enabled her to have dedicated time to really look at some objectives that we wanted to achieve at MFT. So she piloted this between November 2019 and March 2020 in a few of our areas, in a couple of our hospitals as part of the organisation. And then the pandemic hit, so we had to pause it at that point. But what we found was that we didn't feel that we had enough data. It wasn't done in enough areas. So post the pandemic, February 2022 to April 2022, we then extended it for a few more areas as well. And what we did was we asked some areas that were very research active to be able to, we knew they were research active, and we wanted that to be able to see which element of the tool they would utilise compared to some areas that we knew were quite naive in their research and weren't as mature in delivering research or leading on research. So that's what we did. And we did in children's, we did in our women's and maternity services as well. And we also looked at our genetics department. And then we asked for feedback. It was qualitative, some quantitative, but mainly qualitative feedback from the appraisers and the appraisees about how they felt that tool, how useful was it, and whether we needed to tweak it going forward. Next slide, please, Declan. So this was some of the feedback that we got from it, some of the anecdotal feedback. So it helped new starters really see the relevance of research activity. Someone said they had little knowledge before of research, but now I have a slight understanding. Next slide, please. We were interested as well because when we looked at it, we asked them which sections they felt were most relevant, and the top left-hand section, the exposure and the engagement, was a section that people really related to, and that really demonstrated to us that actually, if you are quite well on in your research journey, then this perhaps isn't the tool for you. So I manage clinical research delivery staff, and that probably isn't the tool that I would utilise because all their appraisal is based around research. But actually, it was really for those individuals who hadn't had a lot of exposure engagement with research. It was really hooking them in and really signposting them to the next stage of their progression of their research journey. The managers felt the guidance was really relevant to the appraisees. They really valued it. The appraisees didn't always think the same, which was quite interesting in itself. And it's whether they actually then understood, I think, from our point of view, our organisation's real drive from a research perspective and what their involvement is in research, and understanding that research is everybody's business. And for me, that comes down to the cultural changes that may be needed across different parts of an organisation. What everyone did agree was that it did support our trust vision and our trust MFT MMAP strategy as well, which was what the fundamentals was, which I was really pleased about. Next slide, please. So the conclusions that we came to was that there was a slight disconnect between what the managers thought the tool was going to be and what the junior colleagues, their direct reports, felt it was regarding the strategic priorities. And we felt that was, like I say, due to perhaps the leadership and being in a more senior role, that some people understood what the strategic priorities were. And I think it comes down to embedding research across the whole organisation through a variety of forms, not just appraisals as well. What we also felt at the time was it was a really useful tool. It was a voluntary tool and an optional tool. We weren't mandating it. So I think one of our speakers to come this afternoon, it's been mandated within their appraisal tool in their organisation. We've not done that currently at MFT. However, things have been moved on since I've started presenting this, and we're actually going through a review of our appraisal documentation. And there's a task and finish group of which one of my matrons is going to be part of, where we're going to see whether we can get this embedded within it, even if the tool's embedded, and then people can utilize the tool. And And also the question was asked of me, do we want to mandate it? Because then does it become a tick box exercise rather than it being really meaningful and actually somebody wanting to take that forward as an objective going forward? We discussed about the guidance being more suited to those less involved in research, which I've already mentioned. And it definitely is, it really creates that really rich initial conversation and that signposting. And like I said, it wasn't prescriptive. Now, the signposting was a really important element because the managers felt that they needed guidance on how to utilise the tool. Because it's fine asking these managers to do it like yourselves, but actually you need to be equipped with, if you get the questions asked of you, where do you go next? So then we created a bit of guidance. Next slide, please, Declan. Thank you. So this was a bit more about what we'd actually expect, how we would expect the tool to be created. And then the next slide after that one, please. So then what I've done subsequently is I've actually presented at the various different nurse and midwifery and AHP forums within our own organisation to really see if we can implement this at local level. And I think it's fair to say that it is really sort of hospital specific, department specific, but it's really taken off. I've been in quite a few meetings only these last couple of weeks where people are wanting to pilot this and really see how we can utilise it. I do feel that then we need to reevaluate the tool, especially in line of our new MAT research plan, which is a 2023 to 28, which is very similar to our previous one, but there's a couple of other elements in there. So I do want to add that to it. I've also been presenting it at groups like this, both regionally and nationally as well. There's a lot of interest in it. A lot of our organisations are wanting to take this forward as well. And then it's really to question whether it should be a mandated requirement, considering everything that I've said already. Would it be, would that be the right way to go forward? Definitely want it to be part of the documentation so people can find it easy. There's nothing worse than having to look on your trust intranet, is it, for something? But if there's a prompt there, then I think it'll make it a lot easier for us. So this is going to be part of the toolkit that Nicola's mentioned. So it is going to be embedded within there. So hopefully, it's not, like I say, the tool isn't prescriptive. You can amend it for your own organisation's use as well. So next slide, please. I think that might be the last of my slides before. So also I just always like to just acknowledge a couple of colleagues who don't work with me anymore. Elaine was the original matron who is now retired, but she actually devised the tool. And then Catherine was the matron who piloted it and did the analysis and wrote the paper up, and she was part of the 70 at 70. So just many thanks to both of them for taking the work forward. It's been a really great piece of work. But I'm happy to take any questions until we move on and Justine joins us thereafter.
Thanks, Janette. That's really interesting. Thinking about appraisals in a new way, and I'll start off with a question, if that's all right.
Yeah, of course.
Thinking about my days when I was working back in the ward, and if I was a matron on the ward, I'm now in research, but I would think, okay, I'm a little bit scared on how I can go about doing this, using this appraisal toolkit with my member of staff. I don't think they're interested in research. I suppose what would you think would be the practical side of things that a ward leader or a leader in any profession would do utilising this appraisal toolkit, in preparation for them thinking, right, I'm going to go into this appraisal and, talk around the bits that are in the toolkit. What sort of preparation do you think that they might need to do?
I think that could be two-pronged, really, Nicola. I think it needs preparation from the appraiser and the appraisee, because some of this could be led by the appraisee as well. It may be that they're interested in doing something, but it could be two-pronged, couldn't it? And I think for me, a lot of the conversations that we're having is at that matron level, that lead nurse level as well, and it's about us as leaders really supporting the culture of research in our organisations, because I think that then enables those conversations to happen. So if you're a ward manager on the ward, I think it's knowing where you can go to. If somebody shows you shows that interest. It's about how do you signpost that individual. So for me, if I was that matron, and I'm hoping that Justine will be able to share hers as well, how she did it, but it's about having those conversations with your ward managers. It's not just about appraisals as well. It's about knowing, all our teams have to do quality improvement work, don't they? And for me, that is the real start in our clinical areas of how we can translate a lot of our work through to audit and through to research as well. So I think by getting people engaged on the work that we're doing anyway, can generate that interest. And it's about how leaders, we can see that transition from things like quality improvement work through to audit, through then to research. And I think things like how we support all our areas will have accreditation programs, whatever we call them, looking at the CQC standards. And I know in our organisation, we have research as part of that. And I think as a ward manager, as a unit manager, department manager, you would know that actually, you're going to be assessed on that when that team coming up to your particular area. And if you have staff who are supporting that research agenda and can support your work going forward, demonstrating that evidence-based practice, I think that would speak volumes. So I think as a ward manager, for me, it's about looking at that bigger picture of how you're going to be supporting research across the organisation, and then to look inwards to see how you do it in your own departments. Does that answer your question?
Yeah, that's brilliant. I think the accreditation point is really, really useful. Has anybody ever had the inspectors coming on their ward saying, "Oh, right, what's going on with research?" Because that's the practice for when the actual CQC come in, and potentially ask that question, isn't it? So yeah, it's really important. So we've got a question in the audience. So Catherine.
Thanks, Janette. That was brilliant. I had two questions really, but Nichola just asked it, so that saved you one there. And the question was, how do you get started and how do you get engaged with the right people to start with? And my second question was, and I ummed and ahed about asking this one, but I'm going to.
Yeah, go
I'd
on.
be really interested to know. You said that you had less engagement from kind of the workforce, the appraisees. What was their feedback? If the management was going in and conducting the appraisals and saying, what's your understanding, and talking about research, what was the feedback from that then? Because I think that's really important. If we
Yeah,
need
I
to
do.
engage with everyone, going in with that information might be quite useful.
Yeah, so I think what it is the disparity in language that we're using. So as a leader in research, or we might be talking one way, but I know that when I go onto the wards, if I can see sometimes the shutters coming up when I talk about research. Okay, so then I've had to reflect on the way that I'm talking about research, and I think, I've been in research for 20 odd years. And I'm thinking, Janette, I've got to change my language. This isn't resonating with this newly qualified band 5. Do you know what I mean? I need to talk differently to the language that they're understanding. And and what do they understand by evidence-based practice, for example? Do you know what I mean? And I've had a really good meeting this morning with one of our local universities about that very question. Is is it really taught at that pre-reg level about what evidence-based practice? So I think Catherine, I think it was the disconnect between understanding what the managers were talking about, and how that relates then to their role. Because as a junior colleague, I remember all them years ago coming out of uni, and the first thing I wanted to do was get my clinical skills up to speed. If someone mentioned research to me, I'd be thinking, oh my God, that's something extra. But actually it's not. It's about making it so it is everybody's business, isn't it? And why are you doing what you're doing, and questioning what you're doing. So, research is on, lots of levels in that ward environment or department environment. Like I say, it's about how does that ward support research. So a really good example recently in one of our EDs at the trust, and one of the diabetes specialist nurses had gone away. They'd done a focus on current research to do with type 1 diabetic patients, and carb counting, and it was up there on a board. I know Nicola's seen it because she liked it on Twitter like I did, but I thought, that is brilliant. That nurse has gone away. She's found the relevant evidence. Do you know what I mean? It's gone up on the board. It's visible. That shows that research is being, sought after. Someone's done a literature review on that. So I think it's again, going back to your original question, I really think it's about the language that we're using and how they feel it is part of their role. And then that brings in the whole thing about, and I could spend spend weeks talking about it, couldn't I? But that then spends the whole thing about job descriptions. Is it embedded within your job rules in your organisation? Because fundamentally it's got to be, because research is everybody's business. So how do we enable that to happen across each of our trusts? You know what I mean? Does that
That's
help
really
at all?
helpful. Thank you. It really
Yeah.
is. Yeah.
Brilliant. Carl, have you got a comment?
It was just an add-on to what Janette was saying, and I totally agree with absolutely everything that she has said. It is definitely about the language that you use, and you know, I'm like Janette and many others around the country. I do a lot of work with undergraduates, and sort of spending the past 4 or 5 years working with them. We're now seeing them come through as qualified practitioners, and they are actually asking the question about research when they're getting into the ward areas. And I think the other point is to pick up on what Janette said earlier, is QI is definitely a gateway to research, because if you can do PDSA and those kind of things and work systematically, you can do research. And I think a lot of it is about fear and culture in nursing. I think we're very fearful of research, the R word. I mean, I smiled when you said that the shutters go down, because I get that all of the time, and it's trying to make it accessible, isn't it?
Yeah, I think you're bob on, Carl. I think what I'm thinking is we need to do, you know, we all do the QI work, and it's about, like I say, how do we translate that to research? How do we equip our colleagues to be able to translate that forward? Because they're on that pathway, do you know what I mean? And we just need to go further down that way. But yeah, I agree as well.
Brill. Anthony, can I bring you in?
Thank you very much. I'm Anthony Jamot, Community Matron within North London Mental Health Partnership, Camden and Islington in London. Thanks a lot, Janette. I think what you said was really inspirational, and it sort of made me reflect on when I first started, my journey first started in terms of research or evaluation, because that's what the word was used to really get me on board, evaluation. I think at that point in time, research might have scared me a bit, and it's a process. So you move from evaluation, and then you would graduate up to looking at more complex research methods and what have you. I remember it was when I did my non-medical prescribing back in 2006, and Professor Fiona Nolan, was very encouraging in terms of evidencing my work, what I am doing, and running an evaluation on my nurse prescribing clinic back then, and simple methods that was used that was really helpful in terms of getting me involved. And you said something that really resonated with me: meaningful conversations as leaders having with staff. I think that's really important. And just to add on that, following those meaningful conversations, it's also about going a bit further as leaders and sponsoring individuals. When I say sponsoring, I don't mean providing them with money, because we know money is tight, but linking them up with your networks, with people who would be able to support them to get where they want to. Look, in probably in one of the meetings that you may have, it's about saying, look, I know a nurse, a junior nurse here, very enthusiastic. This project is coming up. Why can't you reach out to her? Or I'll get her to reach out to you and see how you could support her. Because as junior staff, I think that's needed. And in that way, I think it would be encouraging equity, bringing about equity within the system. When I say that, I mean bringing about diversity, because we know that there are some areas of nursing that are underrepresented in research. So, for example, learning disabilities, mental health. We know there are some groups also that are underrepresented, people from Black and ethnic minority. And I think as leaders, we probably need to think of how we could actually make it more accessible to those groups, both the areas of nursing I mentioned, mental health, learning disability, and people from ethnic backgrounds, how we can make it more accessible and give them more opportunities.
Brilliant. Thank you for that, Anthony. Yeah, some really great conversations there. And I believe Justine has arrived, who is our next speaker, who's going to talk about her experience of I think, piloting the appraisal toolkit. Justine, are you there?
I am. Can you hear me?
Yeah. Declan, can you just
Great.
move the slides along to Justine's slides? Brilliant.
Wonderful. Thanks everybody. I think it might probably help just to give a little bit of context as to what my role is. So as you can see, I'm a clinical I'm a clinical academic, so part of my role is very much embedded within clinical practice. So I'm currently here in a complex major trauma clinic, but then I also have that interface with academia and research side of things. So I'm also one of the lead researchers based at MFT, working alongside Janette. So we have a really cohesive approach to research over in Manchester with AHPs and nursing. As you can see, I'm an AHP by background. So we've very much tried to implement the appraisal tool that Janette has developed across MFT, across all professional groups. So I'm just going to present to you the case study that I've done, sharing the experience of trying to implement this within the AHP workforce. So what we did, I heard, just at the latter end of the conversations now around the PDSA methodology, which is absolutely a great starting point for all our colleagues that are just starting to think and have developed those inquiring mind, really. And this is the methodology that we use to appraise what we were previously doing with the consideration to implement the tool. So we initially presented and launched the tool within our divisional management board for AHPs, and this was back in 2022. And we just thought, well, we'll test the water and we'll use them as a litmus test and see how they respond to that. But then we also used a group of research champions spread across the organisation and paired them up with the managers to see whether or not they actually adopted and felt that there was value in the research tool. So we then reviewed that. We landed with that in 2022, and then we reviewed the process in 2023, and we found that it wasn't routinely adopted successfully across all of the areas. So what we wanted to do then is look at changing that and understanding what the barriers were. I'm sure you've all had the conversations about the barriers to research on the call before. So we just wanted to understand what they were, and maybe we could overcome some of the barriers with an additional piece of work. So, if you just want to, could you move the slides for me, please? Thank you. So what we did, we've used Mentimeter, so it gives us the nice impactful slides that we have here. So the question that we were asking, we went to the clinicians that were using this tool or trying to use the tool. And we also then went to the leaders or managers. I prefer the term leaders, but it just depends which way you want to split your hairs. So this is the clinicians' responses to the question where we asked what were the barriers to the implementation of the appraisal tool and your participation in research. So I think I've just heard some of the comments that Carl was saying around people are very fearful of it, and researchers are, it's far too highfalutin and academic for people to really make kind of connection with. So sometimes we turn people away. So it's a lack of understanding of research itself, but also how the tool could support people through appraisals. And those early careers, professionals that are just, they might have come through an undergraduate programme and they're told that there's lots of research going on in the NHS, and then they land with us as clinicians and actually there's not much visibility of it. So I think it's about understanding that. They're also saying that there's time was an issue. This was one of the barriers, was quite often there wasn't the time to sit down and actually think about what research meant to the individual and how that was actually going to be adopted and driven forward. One of the other key things was around support. So it was felt that not only were managers or leaders not necessarily able to offer support for various different reasons, it was also support from the team. And they didn't feel that research was embedded at that early stages, right the way through the career ladder, and it wasn't necessarily supported widely. So these were the perceptions of the main barriers. Again, it was around resources, as I've heard mentioned just as I joined the call. It's about research, resources and support the infrastructure, really. If you'd just like to move the slides on for me, please. So we asked the clinicians what it was that they wanted us to provide that would help overcome the barriers. Again, unsurprisingly, it's time, it's guidance, it's about training and offering support and networking. So just heard then about meaningful conversations, and I think the meaningful conversations need to start at the ground level, but then also have managers that are receptive to those meaningful conversations, that actually understand what research means for individuals. Because it's not all about, you know, the trajectory to do a PhD and then off to university being a prof. It's about making research meaningful for everybody. And it might be that you're part of the research delivery team. It might be that you're just identifying patients on a ward that might be appropriate for a study, or even starting to think about your evaluation of your own practice, that then can be the first of the baby steps into a research career. So these were some of the comments that were made. And one of the other key factors is around mentorship. And it's having somebody that's actually got the knowledge that can shape the career and shape the pathway and steer you along the pathway. There are so many different options for funding, for support, just about training and education with library services, etc. And unless you have somebody that's actually got that knowledge and the mentorship skills and abilities, that the opportunities would be lost and not fully realised. So these were the barriers that the clinicians identified, or what we can put in place to enable them to overcome the barriers. Team support was a big thing that came through. It's about understanding as a team what your roles and responsibilities are to deliver the research agenda, but making sure that it's quite often seen as a burden because of the time that's required, but that's a burden that's shared by the whole of the team, and the people that benefit from that is the patients, because we all know that research active organisations have significantly better outcomes for patient care. So it's about having that whole team support. And also, just heard again, networking. It's really important to develop those networks to support clinicians, so that, you know, if their mentor's not available, they know that they've got an alternative and can go to a network that will help with that. And it's not always about one person having all the answers. It's about sharing that and sharing the learning. If you could just move the slides for me, please. So we then come to the leaders. So we wanted to understand what the barriers to using this, adopting the research tool was from a leader's perspective. And here we found that here at MFT, there's certainly a disconnect between the senior leaders or managers and those research active and research interested clinicians that are on the ground, busy doing the doing, with the finite resources that we have as clinicians. And what we wanted to understand was what those barriers were and why there was the disconnect. And I'm sure there's no surprise here with the comments. The words that are on here, it's confusing, they don't understand it, they find it expensive, there's not enough time, there's not enough support for them, staffing, again, the staffing pressures. So there'll be no surprises here, but it just reinforces that the clinicians are saying pretty much the same as the leaders. So what we wanted to understand is, right, well, we know that research is important to clinicians and also to the leaders. So we needed to put the two together, and how are we actually going to move this to the next stage and make this successful? Because we've got a great tool now, and it's how can we improve the delivery of that and implementation of that and embedding that in our culture through appraisals. So if you'd just like to move to the next slide for me, please. So this is our plan, and so this is our next section. So I'll take you down through the left column, which is for the development of leaders and a management resource pack, because the one thing that we do realise is that there isn't readily available information for managers and leaders to support clinicians and colleagues through that career pathway. So we plan to do a leadership workshop and engagement session, which Janette and I will be leading on with our divisional director for AHPs. This will be targeted at managers and leaders in the 8 bracket, so from the 8As up to 8Ds. And we plan to start this in June of 2024. And the clear message for the leaders will be that research is not nice to do anymore, it's absolutely essential to do. And to help them understand, we need to help them deliver the research agenda and to improve adoption of the research tool, the appraisal tool, is we need to help them understand the difference between the different roles within research, because I think there's definitely, this needs demystifying. Because as I said earlier, it's not about having the the pre-doctoral fellowship. It's not about going on a necessarily an academic pathway. Everybody can be involved in research as a research deliverer, a research leader, where you're developing the research protocols, and you might have an academic trajectory, or you might be wanting to do the personal awards, or even modules at MRes level. You might just want to dip in and do a module just to test the water. But I think the difficulty at the leader level is, unless you have a research mindset, you might not necessarily be aware of the difference. So you can secure funding for a small pot of money that maybe enable a team to deliver a small piece of research that can evidence the practice that they currently adopt. That would be a team award, and it would be a team effort compared to a personal award to someone that's on a doctoral fellowship, for example. And I think it's about understanding the difference between the dipping in and dipping out, and how everybody can support that research delivery of a small award. Or it might be that we have a study that's ongoing within your clinical area and you just want to identify patients. It's not necessarily about having hours and hours spending with a research team and with patients. Everybody has a part to play. So I think it's about, we need to demystify that and support managers and leaders to understand the difference with the roles. I call it the onion of research. You've got the core in the middle, that are the research leaders that are doing the protocol development, the idea development, etc., down to the outer layer of the onion that might be someone that's just giving participant information sheets out. Everybody can give somebody a PIS. So another key thing really for our managers to really embed this appraisal tool is for us to help them understand, and the onus is very much on the research leaders here, to understand the impact that can have an operational level, and look at the outcomes for patients. So to avoid those revolving doors, what is it that we can do to break that cycle? And it might be something that comes out of a very simple research study, or very simple evaluation of a service that can then maybe rebadged as research, and you get a little bit more into the detail and the granular levels. It might be that we can improve length of stay, we can improve or reduce readmissions, improve patient satisfaction and reduce complaints. What manager wouldn't love to, to reduce their complaints? The other really important thing for us, particularly with the workforce crisis that we currently have, is around staff retention. And making our organisation or employer of choice. So when we have the undergraduates coming through and they come to MFT, they know that we're a research active organisation, and we're not just paying lip service to this, we're actually research active, and that might make us attractive as an organisation. So that would imprint across all of the NHS organisations. We also would like to improve the understanding of leaders for the different starting points and different career pathways. And as I said, it's not just about an academic outcome. And then we plan to do the introduction of the appraisal tool, working through an example of a researcher at various different levels of the career. So we're going to pair the leaders up with one another, and then going to have a paper person, and an early careers researcher, or somebody that's thinking they're aspirational and they want to do a PhD, and how we're actually going to use the appraisal tool to help that individual work through their career. We will then plan to do a workshop with the clinical teams and the managers to actually make that real time, and to actually have that mentoring session with the leaders and the early careers researchers, or those interested in research. And then we're going to plan the review and feedback. So if I then take you over to the right hand column, so this is then for the clinicians. So it's very, very similar format. We plan to do an engagement and workshop with the clinicians at 6 and 7 levels initially, and research champions. So the research champions, we do have people that are research champions that are band 5s. So if they're a research champion, they will be included in this. But otherwise, we'll start at the band 6s, again, because that gets the leadership levels where there's that disconnect. Again, the clear message about it's essential to do. This isn't nice to do anymore. That's in our rear view. We're now looking forward. It's essential to do. And again, it's about understanding and improving the clinicians' understanding of what the the different roles are for research, just the same as we've got with the managers. And then we need to demonstrate the impacts of research at a clinical level. So we can look at improving patient recovery and, again, patient satisfaction. We all want our patients happy as they're leaving the hospital and then coming back in again. Improving efficiency. So again, this will have a direct impact on the resources that we have available to us clinically. When we're thinking about the workforce crisis, we need to make sure that we're working to our optimum and that we're keeping our staff and reducing waste. And we're maintaining our retention, we're keeping our attrition of staff to an absolute minimum. And also mapping out and almost sharing the career opportunities that are available at all different levels of research, irrespective of what grade you are and irrespective of what role you have. Everybody has an opportunity to get involved with research. And that fits into the next section down, which is around the different roles in research, and everybody can do something. If that's patient identification, we can have individuals consenting, doing the interventions, right the way through to developing the research programmes that we're planning. Again, we'll introduce the appraisal tool, working through it within pairs. So this is where we'll bring the senior clinicians in that can then do the mentoring and the encouragement and the coaching to make sure that the appraisal tool is being adopted, and they've got the information that they need, which will come from the manager's resource pack. So that will follow through with them. And then we can once we've got the 6s and 7s all happy with things and we've got great feedback from them, we can then implement with the team. And then we'll come back and do a final review of this group and then just roll it out across the trust. And the plan also will be that although this is the AHP plan, a lot of this we can use, so the resource packs for both the clinicians and the managers and the leaders can be utilised across professions. This isn't just going to be for AHPs, this can be shared across the organisation in all professional groups. And I think that's my final slide.
Brilliant. Thank you so much for that. Really, really interesting. I've written loads of things down. I love your analogy of the onion. I'm going to be using that. And I think maybe Carl is going to start putting his slides up in the interest of time while I just talk through this, if that's all right, Carl, if you want to put your slides up.
Of course,
I'm going to do a bit of a Slido with the audience to stimulate some conversations. But, if you're sitting there thinking, where do I even start? I don't even know who my research department are. I think the ask of us is to go and speak to your senior management teams in your organisation. Okay, Manchester are doing this. Could we have some sort of resource for managers, for leaders, to help us understand how we can facilitate this more? The SORT tools coming out, the Matrons and Health and Care Leaders Research Toolkit is coming out soon as well, and all that can help support it. And we would love to see some of the resources that you create that might be useful for other organisations as well. So thank you so much for that, Justine. So everybody that's on here, feel free to pop your hand up and talk as we run through this. But Carl's just going to run through some of the questions, and we'd like to get your feedback on a Slido. So thank you so much, Justine. Carl, if you want to.
Yeah, no problem. Thanks, Justine. People have started already. So basically, we've got 3 questions for you, and if you can scan it with your mobile, or you can go to the slido.com link and then use the number. And basically, the question is, what might be the benefits of adding research into appraisals in your area? And we'll give people a couple of minutes to do that. I also liked the onion analogy, and I am also going to be stealing that one.
I'm happy to share my onion.
Yeah, that's good. Onions are for sharing.
Yeah, absolutely, absolutely. And when you describe it to individuals about the onion and the different layers, they're, oh, well, I didn't even think of it like that. And it's not everybody's going to be in the middle, and it's about the more layers to the onion and the more involvement that we have, it makes everybody else's job so much easier and makes it more deliverable. Absolutely, totally agree, Justine. Well, that's great. I mean, the biggest one there is obviously, awareness. It's come out twice. It's so big. Obviously recruitment as well. There's a lot of research out there that shows the more the hospitals that are and clinicians that are involved in research, their patients do better. So giving those patients the opportunities to get involved. I absolutely love all of this. So we'll just give that one another
another 30 seconds or so in the interest of time, and then because the two guest speakers have done such a fantastic job, I'm sure there will be questions for them at the end. Just one more person typing. I'll just let that person finish, and then we'll move on to the next.
I think also,
question.
Carl, that thinking about, and it's not just appraisals, is it? It's when you're supervising staff, clinical supervision, P&As is also a thing, you know, and PMAs, you know, using that as an opportunity to help spread the word, and, you know, so training the leaders, but as well as training the people that do supervisions of, you know, using your resource pack that you're going to be all sorting in your organisations. Yeah, all opportunities when you're talking with staff to just help develop that buzz around research, because actually it is a bug when you get in there. It's a get the research bug. I know there's a lot of fear out there, but it is amazing to actually start to utilise evidence-based practice, which we all learned in our training. But how do we actually do it in real life?
Absolutely. Okay, so again, in the interest of time, I'm going to stop sharing that one, and then what I'm going to do is I'm going to put the next one up.
Got a comment in. I trust definitely doesn't mention research in our appraisals. Hadn't thought about mentioning it in appraisals. So I think it's a good idea. Brilliant. This is what we want. It will, and there is research, as Carl said, that having your organisation that's research active does help recruitment and retention. It helps quality of patient care. It helps a lot of things.
Absolutely. So question 2 is, what do you feel the challenges in setting this up might be, and how might you overcome them? So same format, either use the QR code or use the link that's on the bottom of the slide.
To remind everybody, this appraisal toolkit is in the Futures NHS webpage as well. So if you want to reflect on this afterwards and have a think about what each of those sections, the 4 sections that Janette was showing, what it means to you, and, you know, bespokely, we've got different professional groups in here, different organisations. You might have people from primary care, community, mental health. You know, it might be different for different organisations.
I do like people have acknowledged buy-in and bureaucracy. And again, picking up on the scale of implementation one, going back to what both of the speakers today were saying, I'm guessing in Manchester they didn't just go, right, everybody's doing this. You know, it's that scalability, and starting small, making sure it works in your local area, and then scaling it up from there. Yeah, again, someone's put it on the too difficult pile as well. Yeah.
Tick box exercise.
Yeah.
Good comment to have in there. This is not a tick box exercise. This is about us making it everybody's business, improving the culture together.
Yeah. And to give an example there, to give a real clinical example, when COVID started and I was setting up the COVID research team in Leeds, I was told by an intensivist that nobody would prescribe dexamethasone. And what did recovery show? That it saved the lives of the, you know, 2/3 of the sickest patients, and then unsurprisingly was given to everybody. So, you know, N of 1 opinion versus research where everybody's involved, you know, it just shows. I bet totally understand, you know, the NHS is under unprecedented pressure at the moment. Time, engagement and all that sort of stuff's really important. Yeah, I like the buy-in from the top as well. I tend to favour a bottom-up, top-down approach, attack from all angles. And I don't know if the two from Manchester had comment on that, how you got buy-in from people above and people below. Did you attack it from multiple different angles, or how did you manage that?
You could see from my presentation that that's exactly what I've done. So I've gone from the top down and then the bottom up. So, and what I've found is that if you light the fire underneath the clinicians that are out there doing the doing, and then that it raises the energy levels, and then the managers almost get sucked along, you know, swept away with it. But then you need to then have the knowledge and the skills to support the managers and to help engage them and engage them in the right way. So I mean, we've got a really strong research culture from the top down, and probably we're getting there from the bottom up. So it's just our disconnects